Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, we focus on the key HIV studies from CROI 2024 that are influencing clinical practice. I'm joined by Dr. Joseph Eron, who is the Herman and Louise Smith Distinguished Professor, Chief of the Division of Infectious Diseases, and Director of the Clinical Core at the UNC Center for AIDS Research at the University of North Carolina at Chapel Hill, as well as Dr. Monica Gandhi, Professor of Medicine in the Division of HIV, Infectious Diseases, and Global Medicine, and Medical Director of Ward 86 HIV Clinic at the University of California, San Francisco. They will discuss new data surrounding long-acting antiretroviral therapy, comorbidities and coinfections, as well as new therapies on the horizon for HIV treatment. Let's get started and hear from our experts.
I'm going to actually talk about long-acting ART in this section. And there was some really exciting data from CROI on long-acting, what's currently approved in low and middle income countries with cabotegravir and rilpivirine. And then there was important data from more of a high-income population from the ACTG on long-acting CAB and RIL, and then kind of a more off-label approach, which I'll talk about. So the first study that got a lot of attention really is the question of using long-acting cabotegravir and rilpivirine in low and middle-income countries. This is the CARE study, and importantly, CAB-RIL, which was approved in December 2021 by the FDA, has not been endorsed yet by the WHO to be used in low and middle income countries. Part of that was the question of NNRTI resistance. Part of that is the cold chain with rilpivirine, and also the studies of cabotegravir rilpivirine that had been performed weren't in LMICs. And so this was the study that looked in Sub-Saharan Africa. It's specifically in South Africa, and it was using what's called a public health approach. What does that mean? That means that monitoring is not going to be frequent in cabotegravir and rilpivirine. It's going to be more in line of what's practiced in those settings. So this was a study of 512 adults. They all were virologically suppressed on their stable oral ART. That's really important. So because they were virologically suppressed, no resistance testing was done in the plasma. However, PBMCs were gathered to do archived resistance testing after, but that did not inform whether you put them on cabotegravir and rilpivirine or not. That was done later in the study. And again, they were all suppressed on oral ART. They were then randomized. The cabotegravir and rilpivirine oral formulation was optional. They were randomized really to long-acting treatment, cabotegravir and rilpivirine, versus staying on their standard of care oral ART. And the primary endpoint of this study is looking at virologic suppression at 48 weeks. This study will go on to 96 weeks, and that data is actually in progress. But this is presenting the 48-week data. And so importantly, if you look across the demographics of this group, 57% female, which is typical in the region, 20% had a BMI of greater than 30. The reason that's even of interest is cabotegravir troughs can be lower in those with high body mass indices. So it's something we look at with cabotegravir rilpivirine. And there was prior exposure to NNRTIs, which would imply that there could have been development of NNRTI resistance. That's 74%. But most were on dolutegravir, lamivudine, and tenofovir at entry, 92%. Now, though this data is being presented here, again, the investigators did not know this, that there was a baseline level of rilpivirine resistance mutations, 13.5%. There was 10% of intermediate high-level resistance. Again, this is in the archived DNA from the PBMCs. Cabotegravir, there was a surprising 16.1%, but 8.3 high level, again, in that genotype archives. And then one other really important point here is that subtype A1 comprised 57% of sequences. There had been a question about subtype A1 and A6 raised in the original FLAIR Atlas 2M as being more associated with failure, but we'll talk about that in a minute. It was really a 97% virologic suppression rate at 48 weeks and a really impressive rate of on-time injections, 96%. Almost 83% got every single injection on time. There was only one failure in the study on the long-acting regimen, and that failure did eventually develop intermediate CAB resistance and high-level rilpivirine resistance, but that was one out of 247 individuals. So what is the upshot of this data? There were a lot of questions that came out that I think it's important to tell this audience because a lot comes out of the questions. A1, A6, that was one question. Really seems, if we think about it, and a lot of people weighed in on this, that probably A6 is more associated with sequences from Eastern Europe and a little more associated with failure, but A1, especially with this data, is not something to be concerned about when you use cabotegravir or rilpivirine. So we still have to focus in on A6 for that later. Second is that archived genotype resistance mutations is not the same as having viremia with documented in the plasma viral resistance mutations. And then the third is that a lot of people were concerned still about that archive resistance mutations and want to wait for that 96-week data. They're all virologically suppressed. They all had good on-time injections. How long can you last if you have archive genotype resistance? So I think those were the three biggest things that came out of the questions and the discussion after the meeting of this data. There was really good tolerability, as there has been across these studies, meaning that injection site reactions tend to calm down and not be very high level. There was only one person with a grade 3 and only one person who discontinued because of injection site reactions. But importantly, and the investigators really made this point in the question answer as well, people really liked long-acting ART. There was, this is consistently seen across these studies with long-acting cabotegravir rilpivirine, but that liking it may be even more so in a setting where you have stigma, where you don't want to tell people you're on oral ART. You can just go into the clinic, get it, and then come back every 2 months. And I should have stressed that this is an every 2-month cabotegravir rilpivirine administration strategy. So second study that involved using long-acting cabotegravir and rilpivirine, again, in more low and middle income countries. This is a study done in the IMPAACT Clinical Trials Network, which studies adolescents, children, and it was nicknamed MOCHA, but it was adolescents who were living with HIV who were then switched to long-acting cabril, not a randomized study. What cohort 1 were adolescents who were just put for 16 weeks on cabotegravir and rilpivirine, and then some of cohort 1 went over to cohort 2. But the reason that cohort 2 is important is this is a longer-term study to see the length of duration of durability of long-acting cabotegravir and rilpivirine. It was 5 countries: US, Uganda, Botswana, South Africa, and Thailand. And adolescence was defined as less than 18 years old. And they were all had a kilogram weight of above 35 kilograms. That is actually, where the guidelines allow cabotegravir and rilpivirine to be given, because it hasn't been studied in those younger populations, may need a lower dose. So that's where we are with the kilogram cutoff. And 144 in the cohort, and they were followed in this particular outcome study. This was just the first look at 24 weeks. So that we're going to look at the virologic suppression rate at 24 weeks. And again, they're going to be followed out actually to 96 weeks. So this was a young population, 51% female, 74% Black, 92% vertical HIV acquisition. That would imply a lot of underlying resistance, which wasn't measured in the study, but I think that's important that so much vertical HIV acquisition. Low body mass index, they were young people, so it was 19.5 was their median BMI, and median weight was 48 kilograms. Grade 3 injection site reaction was just 1, and they made the point this was non-sterile abscess. So the important efficacy is that HIV RNA, they all started with HIV RNAs less than 50, that was maintained in 96.5% of participants at week 24. So again, really high levels of retaining virologic suppression in both of these studies in more low and middle income settings. And in the PK analysis, adolescents didn't have particularly high cabotegravir rilpivirine levels with those low BMIs, for example. They're essentially comparable to those in adults. So there was a lot of push, a lot of interest from the pediatric HIV community, adolescent community to say, don't leave that population behind. And they absolutely need access to this therapy, especially given the issues that we do see with adherence in adolescents and vertical transmission populations. And then that leads to the next question of this conference, which really became around the question of, can you use long-acting ART in people who have adherence challenges? And that's what we're going to discuss next. So this is the 5359 study in the ACTG Clinical Trials Network. Now, this is a little bit of a complicated study. I will boil it down to say that what this was meant to do was to look at participants who have documented adherence challenges, hard time taking the oral ART for so many different reasons, and trying to use long-acting ART in that population, because that's a population we've been historically very interested in using long-acting ART. It's used for contraceptives and antipsychotics, and the substance use, we really want that long-acting in this population. So these participants were specifically enrolled who had documented poor viral responses to oral ART. But the way that this study worked is that for the first step, everyone went into the first step. Up to 24 weeks, they had to be on oral ART, and they were given conditional economic incentives to actually get their viral load suppressed. Because to go to step 2, when you went into long-acting for half the participants, they should have been virologically suppressed by the design of the trial. So it was really not yet studying necessarily in people with ongoing viremia, but we'll talk about that. And then what happened is that the primary endpoint was shown in this meeting because the DSMB had just looked at the study on February 12th and said, oh, we see a clear difference between the arms, and we want to stop this study and allow everyone to go into a long-acting phase of the study, which would be step 3. So that already implies that it looks like a long-acting cabotegravir and rilpivirine looked good in this population, and that's exactly what happened. But let me tell you exactly how that played out. So these were 30% female, and just importantly, there was injection drug use in 14%. But when they got randomized to using long-acting versus staying on oral ART, this is again a population that has hard time adhering to oral therapy, and actually 17% were actively viremic at the time that they got randomized. Again, that wasn't necessarily the design of the study, it wasn't, but again, this is a population that has a hard time. So it was 24 actually in the long-acting arm were randomized with active viral loads that were up. And the safety was fine. ISRs, injection site reactions, were tolerable. I will say that the primary outcome of the study was meant to be a combination of both virologic failure or discontinuing the treatment. That primary outcome was not statistically significant, or it did cross the confidence interval, did cross 0, even though it's heavily tilted towards there's being a difference. But if you separate out 2 secondary outcomes, the outcome of virologic failure, which is of course an important outcome in clinical practice, did show that the long-acting cabotegravir rilpivirine arm had superiority compared to staying on those who got randomized to stay on standard oral ART. So 7.2% virologic failure rate in long-acting Cabril versus 25.4% in oral ART. And the other secondary outcome that was statistically significantly superior for the long-acting arm was treatment-related failure. So discontinuation wasn't statistically significantly different between the 2 arms, but these 2 secondary outcomes were enough for the DSMB to say, stop the trial, let's go on to let everyone have long-acting Cabril, because we see clear superiority of long-acting Cabril in patients who have adherence challenges. And I think that was the right call, because those who have adherence challenges are a population that really can benefit from long-acting cabotegravir and rilpivirine, and the superiority is in a way not that surprising that this is a population who really needs this. So is there any other data that verifies what we just talked about? Well, we have this ongoing demonstration project at Ward 86, which is our HIV clinic in San Francisco. It's publicly funded, and we now have 286 people on long-acting cabotegravir and rilpivirine out of our 2,600 patients in our clinic. But importantly, we when we started this project, we allowed patients in our demonstration project to be on cabotegravir and rilpivirine even when they were viremic, because they had a hard time taking oral ART for lots of different reasons. And we had presented last year at CROI and then have published ever since some of our outcomes on those who are viremic. And I'm going to focus just again on those who started with viremia here in this analysis that we presented at CROI 2024. So we had 59 people who had started with viremia. And the question of this particular analysis is, do they have durable virologic suppression? How long does their virologic suppressions end up being if they start with active viremia? And our patient population is complicated, lots of housing instability over 80% and lots of 61% methamphetamine use. But what we are focusing in on here are the 59 people who started without virologic suppression. And the results of this study is that 93% at 48 weeks did have a viral load less than 50 by 48 weeks, and 95% had a viral load less than 200 by 48 weeks. And there's a lot of discussion of less than 200 versus less than 50, what should be using with long-acting ART. I will say in our SPLASH program, our long-acting program, we've decided on 200 as being our cutoff based on this data and some data from UCSD. So kind of longer lasting virologic suppression in these participants. And that was important, though we did have absolutely some people who failed with resistance, and there were 2 of them. So in response to the ACTG 5359 study, and possibly some of these demonstration projects, including our own, the IAS USA on March 1st, leading up to the meeting, did actually endorse long-acting cabotegravir and rilpivirine for those with consistent adherence challenges who are unable to take oral ART. They said the reason they did that, and something I should have pointed out in those 2 previous slides, is this is a patient population who often has a CD4 count less than 200. They can get sick. They have ongoing viremia. They can get opportunistic infections. And if we have a drug that can be used, even though it wasn't studied in big clinical trials in that patient population, we should use it. And then I will end with just one quick case series, which was there are patients with very clear documented NNRTI resistance, and in an increasing manner, off-label clinicians around the US are using a combination of lenacapavir and cabotegravir, again, off-label use in those with NNRTI resistance. So we gathered a case series of 34 people from around the US. They all had adherence difficulties. Most of them had documented NNRTI resistance or suspected, and showed that lenacapavir and cabotegravir seems to work well in this case series. There was a 47% virologically suppressed at baseline, and it went up to 94%. And this is really serves as a call for a study of long-acting CAB and long-acting lenacapavir, which I think is going to be approved in a small way in the ACTG coming up. So I will turn over to Dr. Eron with our take-home points that things are looking good for CAB-RIL, even in low and middle income countries, and cabotegravir and lenacapavir is getting some attention in the help of using it in the study. Thank you.
Well, thanks, Monica. That was really terrific. I'm going to talk first about comorbidities. And this is the REPRIEVE study. Probably everybody is familiar with REPRIEVE. That was a almost 8,000 person study that showed that major atherosclerotic cardiovascular events were reduced by 35% in people on a lipid-lowering agent, atorvastatin, a statin drug, versus placebo. Also in that study, in a smaller sub-study, it was shown that participants who received atorvastatin also had a major effect on their non-calcified plaque. People probably know that it's the non-calcified plaque that's likely to rupture, and that can lead to, obviously, myocardial infarction, stroke, et cetera. So this is a study where they were trying to explain, why did atorvastatin have this effect, which seems to go beyond just lowering cholesterol. And so this is a smaller sub-study. These were people that all had a special CT scan to look at this non-calcified plaque. Like the overall study, people were on average in their 50s. There are more men than women. Obviously, they're all living with HIV. But the thing to show you is they all had a fairly low risk score. Their average risk score was only about 5%. So 5% risk of having a major cardiovascular event in the next 10 years. And of course, we know that people living with HIV, their risk is higher. So what did they find in the study? They were looking for explanations. And what they found is this protein that I've never heard of, PCOLCE, which turns out it's an enzyme that helps lay down collagen, right? And it turns out this expression of this enzyme was highly associated with a decrease in this non-calcified plaque. And if you think about it, the problem with the non-calcified plaque is it ruptures. And by increasing the stability of the plaque, at least that's the hypothesis, this having this higher protein would actually decrease the risk of plaque rupture. And the important thing is that this goes beyond just the change in LDL cholesterol. And that may be why in the study we saw a stronger effect on major cardiovascular events than we might have anticipated in what we thought of as a fairly low-risk group on a statin. So this is an important thing that helps explain why statins in people who are living with HIV may have even more benefit than just lowering cholesterol. So then to go on with this metabolic hypothesis, this is a study of semaglutide. This was looking at something called metabolic-associated steatotic liver disease. We used to call this NAFLD, but basically it's fat in the liver, which for the most part, not good for you. And this study looked at people who had documented fat. So they took an MRI of the participants. In order to qualify, you had to have a large waist circumference, you had to have insulin resistance, and you had to have at least 5% of interhepatic triglycerides. So IHTG, interhepatic triglycerides. And this is an open label, single arm study of semaglutide. And basically it's kind of low dose semaglutide, right? They only got up to 1 milligram sub-Q weekly. And I'm sure many of you know that the dose that is recommended for diabetes and weight loss is 2.4 milligrams sub-Q weekly. So what did the investigators see in this study? Here are the baseline characteristics. Again, they're in their 50s, more men than women, though 37% cis women and 6% trans women. And they had a very high BMI, which you would have expected. 35 was the median, and they had quite large waist circumferences. But they're suppressed on therapy with a high CD4. And what the primary outcome, there was a 30% relative reduction in this. 58% of the participants had a 30% relative reduction in intrahepatic triglycerides, and almost a third, 29%, had complete resolution of this intrahepatic triglycerides to less than 5%. The study wasn't really powered to look at subgroups. It's a relatively small study, but women, Hispanic and non-Hispanic white people, and people over 60 seem to have the greater effect. Not surprising, weight improved, BMI improved, waist circumference improved, insulin resistance improved. The mean weight loss was 7.8 kilograms. And those of you who are bad at math, that's about 16 or 17 pounds, because I'm not so great at math, despite only 1 milligram. And then obviously this weight loss was correlated with the fat loss. There was some decrease in muscle volume, which is a concern, but there was actually improvement of the physical condition. So it appeared that semaglutide had an overall benefit, but obviously there's a lot of discussion about semaglutide and the benefits and risks, and we're going to need to study this further. So flipping over to a comorbidity, which is a co-infection. These are sexually transmitted infections, and I'm sure you've heard of doxy-PEP. This is taking doxycycline post-exposure to prevent STIs, chlamydia, syphilis, and gonorrhea. There have been several large studies, one led by Annie Luchtemeier, that showed that this doxy-PEP given to men who have sex with men and transgender women who have sex with men or other transgender women really reduced sexually transmitted infections in the context of a study. So this is not a randomized study. This is looking at 3 clinics in San Francisco where it was strongly recommended for doxy-PEP to be given to cis men and transgender women if they'd had a previous bacterial sexually transmitted infection, and to offer it to cis men and transgender women with multiple partners, even if they didn't have an STI. It looks like once doxy-PEP recommendation was introduced in the fall of 2022, so about 18 months ago, the rates seem to go down. So let's take a look at this in further detail. The predicted trend was stability of chlamydia, and there was a substantial decline. Again, if we look at syphilis, again, the predicted trend was to continue to maybe rise slightly. And after this recommendation, the trend decreased dramatically. And someone with a sharp eye might argue, well, maybe it was decreasing even before this doxy-PEP recommendation. But I think in San Francisco, people were using doxy-PEP even before the recommendation. One thing that didn't change is actually gonorrhea. In fact, gonorrhea was decreasing and it actually appears to have stabilized. So instead of a 1% per month or 2% per month decrease, there was actually a 1.8 per month increase in gonorrhea. And though we don't know yet, my guess would be that gonorrhea in San Francisco is likely to be tetracycline resistant. So doxy-PEP works for chlamydia and syphilis in very high-risk people, but doesn't seem to have impact in gonorrhea, at least in San Francisco, and we'll learn more. So the take-home points for comorbidities and coinfections is the proteomic analysis from REPRIEVE helps explain why there was a decrease in non-calcified plaque in people on pitavastatin. In the slim liver study, semaglutide was associated with significant reduction of intrahepatic triglycerides or intrahepatic fat. And there were other improvements, but that was a single-arm study. So we have to kind of look and see in comparative and larger studies. And finally, in San Francisco, among men who have sex with men and among transgender women, by implementing doxy-PEP, there was a significant decrease in chlamydia and early syphilis, but not gonorrhea. So what about what's coming? So Monica talked beautifully about long-acting injectable therapy that can be given now every 2 months with a once-a-month starter boosting. But what about other long-acting alternatives? So this is a study of oral weekly therapy. And this is oral weekly islatravir and lenacapavir. Lenacapavir, is a capsid inhibitor, an approved agent for people with highly resistant virus. Islatravir is not an approved drug. And you may have heard about 2.5 years ago that studies were stopped with islatravir because of a decline in lymphocyte counts that also led to a decline in CD4 counts. So what happened over the last 2.5 years or so, there was an intensive study about why islatravir caused a drop in lymphocyte count. And it became apparent that the dose that was chosen was too high. At a high dose, islatravir has toxicity to lymphocytes. So this is a study, again, people who are suppressed, and Monica made that point about the CARE study. People who are suppressed tend to stay suppressed. And in this study, everyone had to be on BF-TAF or bictegravir FTC TAF. And it was a 100-person study, essentially, who were randomized either to stay on BF-TAF, or go to islatravir plus lenacapavir once a week. So it's essentially one pill once a week. Actually, in this study, it'll be 2 pills, but it'll be made into 1 pill, I'm quite sure. And to see whether suppression was maintained, and especially to see whether there was any impact on lymphocytes. So this is the week 24 data. You can see the population. There were about 52 people in each arm, participates in each arm. About 20% were women, about actually 35% or so were Black. So that was certainly, and another 25% or so were Hispanic. So good enrollment of people with color, high CD4, low viral load. Really, the suppression was virtually the same, almost exactly, between the two groups. There was one person that had virologic rebound on islatravir, lenacapavir, with a very strict definition, greater than 50 at 24 weeks. As it turned out, this person stayed on therapy and resuppressed at week 30, no resistance and adequate PK. And then critically, what we saw is there was no difference in CD4 count over time, and no difference in absolute lymphocyte count over time. No person discontinued treatment due to a decline in CD4 or ALC. Basically, there was really nothing remarkable between the two groups. None of the serious adverse events were felt to be secondary to the medication. While we're at the once a week thing, there were oral weekly treatments in development. There was a once weekly integrase inhibitor that was shown to have substantial antiviral effect. So this is a potential to be combined with either lenacapavir or islatravir in the future. And presumably, we don't know, it will have a high barrier to resistance. And then there was another NRTTI, islatravir is an NRTTI that actually had similar activity to islatravir. And we were told that perhaps would have a different tolerability protocol than islatravir and perhaps could be given as a prevention as often as infrequently as once a month. And then finally, there were a whole slew of studies on broadly neutralizing antibodies and HIV treatment. I think the take-home message here is this is something to look forward to. There were studies in people suppressed on oral therapy who were switched to long-acting therapy, and there was essentially mostly maintenance of suppression. The ACTG 5357 study, there were cases of what's called virologic failure, but these were very low level, very conservative definition of virologic failure, though there was one participant out of 71 that did develop resistance to cabotegravir on this study. There was a very interesting study of 3 BNABs, no small molecule, presented by Boris Yulg. Most of the people maintained suppression, but not all. So this is something we really need to look at carefully as treatment with long-acting neutralizing antibodies goes on in the future. All right, so our take-home points. Switching to oral once-a-week islatravir, lenacapavir, similar efficacy, similar stability of absolute lymphocyte counts when compared to BF-TAF. There's some additional once-weekly therapies that look really interesting. And then BNABs, broadly neutralizing antibodies, either in combination with a small molecule, lenacapavir in one study, cabotegravir in another study, look good, but still not ready for prime time, and the studies are ongoing.
There's some really good questions here.
Go ahead, Monica. You had a chance to look at
I'll ask you some, and then maybe I could do the long-acting. One question is, what dose of pitavastatin was used? I think it was 4 milligrams.
4 milligrams, correct. 4 milligrams, yep.
And then do you think there's any concern with decrease in absorption of ART in patients on semaglutide?
That's an excellent question. I don't know the answer, but I don't think so. It's subcutaneous, and I don't know of any biological reason. I guess if there's decreased stomach emptying, I think if anything that might increase absorption as opposed to decrease absorption. But it's
only if you have a lot of nausea or vomiting or diarrhea at the beginning, but that's why we go really slowly. And
yeah, I don't know of any data, but it's an excellent question.
I actually think that what Dr. Patel asked is pretty important, that people were surprised about the CARE study, to be honest.
Yes.
People were like, wait, what? It's 97% at 48 weeks. I think and it's A1. So I think we're done with the A1, A6. That's good. There was 57% of A1. So I think it works in A1 subtype. But yeah, that degree of archived resistance and that degree of cabotegravir resistance, and maybe we can use that opportunity to talk about that, was surprising to see those rates. And it was kind of divided into the optimistic or pessimistic. So the pessimistic group was like, let's wait till 96 weeks. This is going to break through. And the optimistic group was like, well, maybe these are kind of going away and they've had it a long time, but it's not the dominant virus in their bloodstream. And if they're virologically suppressed on TLD, then, they're going to stay suppressed. This is a good group, that was able to stay suppressed, and they're coming in for their injections, and maybe it's going to be fine. So everything, I think, is going to hinge on that 96-week result. People are looking at it.
Yeah, I would add that they didn't actually share the mutations, right? And some of the integrase mutations are just not important. There's the 97 T to A transition. That's a polymorphism, doesn't impact cabotegravir. So I think we need to see what mutations were exactly archived. But I think the whole audience was absolutely shocked, just as Monica said. And it's hard to know exactly. And I agree that getting longer data is really important. So,
but I will add an insight that I'm almost sure the WHO, well, I know now, I think the WHO is going to endorse CAB in low and middle income settings. And I think that's the right thing to do based on this data. And that means that we'll get more studies once it's out there.
What about the adherence rate in the standard of care oral group in ACTG 5359, Monica?
Yeah, there wasn't drug levels monitored, which is one good way to look at adherence, but generally the thought is that it was lower because, again, this was a patient population that already had documented those long history of adherence challenges. So that is actually the idea that if you really can't take oral pills very well, that's why we want the long acting to help with that. So it's likely to have been lower. And that, like you just said, it probably led to this superiority. One thing on doxypep is David Palm asked a really good question on take-up of meningococcal vaccine. We weren't able to talk about the fact that I think meningococcal vaccines kind of gone for gonococcal protection based on the ANRS or the longer-term studies from IMPAACT. So I think we're just everyone's kind of looking for the product that's going to study a designated gonococcal vaccine. And based on what you just said, Joe, it seems like we need a gonococcal vaccine because doxypep is not reliable for that.
Yeah, what I presented was an observational study, a San Francisco wide, and I don't think there's any data from that study on whether people took the doxypep right after sex or waited a day or two. I don't think there's any way to know it based on, we're just looking at accumulated
surveillance
data from San Francisco, surveillance data. So presumably there's a cause and effect. It was the doxypep recommendation that led to this decline. That's probably true, but again, it's observational data. I think if the fact that gonorrhea didn't go down actually makes me think it's probably correct. It probably is a causal observation, but to prove causality is hard work. So one thing that was discussed at the conference and has been an ongoing discussion is actually dolutegravir resistance, especially in lower middle income countries. And there was really a great discussion, and Monica could lead it about, one, how common it is, which depends on what you think of as the denominator, but how do we identify people, especially in low and middle income countries, who may be at high risk for this? And Monica, why don't you go ahead, because you've given this a lot of thought.
Yes, I mean, I think in general, the overall message is dolutegravir resistance 5 years into the rollout is low, especially in anyone who's naive, especially who's suppressed on TLD. So there's not that much panic about it. It's more starting to really think about what are the risk factors for developing dolutegravir resistance, because there is dolutegravir resistance in certain subsets. And I think the risk factors are being on dolutegravir monotherapy, of course. Children seem to have higher rates of resistance, and then having a lot of NRTI resistance in the past, and then not being persistently suppressed. Those who have continuous virologic failure, it's probably kind of on and off adherence, and that's selective drug pressure for dolutegravir resistance. So what the WHO, I think, is launching is really trying to get at these denominators, like Joe was saying, trying to get at the actual numbers. And I would look to South Africa possibly for a really nice way that they've decided in their latest guidelines that just got released. They are going to only sequence those who have persistent failure, 3 viral loads above 1,000, and have some objective metric of adherence that shows not taking it all the time, like even pharmacy refills or a drug level. And then in that group, the rate of resistance is probably high. And then, like you said, Joe, we have to look at transmission of those viruses. So I think no one's panicked. It's the right thing to do to look into it 5 years after rollout of TLD to start doing really incisive studies to give us an idea.
So there's a lot of additional questions. One question is asking about if you have a patient in front of you that's suppressed but has an archived rilpivirine resistance, would you give them CAB rilpivirine? And to me, it's like a risk-benefit sort of thing, right? I mean, if they're suppressed on a single tablet and they have insurance and they're not living on the street and they're taking their medication, I don't know if I would take that risk, because if you end up with cabotegravir resistance, you essentially, until we get better drugs, are really, that person may end up on a boosted regimen for the near or far future. On the other hand, as Monica has shown over and over, if the person can't take their oral medicine, if they've documented that they're having trouble with oral therapy, or they're going to give up taking oral therapy, then it's a different calculus. So that's how
I'll tell you very much what we're doing, because it's an excellent, what you just said is so right on, that like, we don't want to lose that cabotegravir. And because we're lucky here, and I mean, in this kind of high income setting, if we have rilpivirine resistance on a genotype archive, we'll give them, and they can't take oral ART because we're very respectful of that population that says they can't do it. We're going to give them len, CAB, and rilpivirine. That's what we're doing, because we have that option, off label to give lenacapavir. So we get nervous on that archived resistance for sure. And that's why everyone was so surprised by CARES. And I'm so excited to see ongoing follow-up of CARES.
And then Jennifer Kaiser, who's involved in 5359, said that there are dried blood spots. It is important, the 5359 data, the LATITUDE study, that was actually a presentation of the DSMB report. There's a lot of analysis that needs to go on. The oral therapy people were seen less often, though people were supposed to come in only for their injection on certain months and not have viral load tested. But there's a good point made by one of our listeners about if the oral therapy people were seen less often, maybe that was a reason they were more likely to stop taking medication. And then the issue of continuous doxycycline. Monica, you're maybe better than me. I don't know. I think what was studied was doxypep, not continuous doxycycline. Though I'm sure for some people, with very active sex lives, it might be close to continuous, but I'm certainly not recommending that. I don't know about you, Monica.
I mean, one thing that we didn't talk about this is there is an ongoing talk of resistance in other strains like Staph aureus, or driving up tetracycline resistance and, gonorrhea and even multi-drug resistance. So it's not like that isn't a concern. And because of that, we're trying to shorten the period of time that you would be on doxy, meaning trying to reduce the number of courses of doxy you'd actually need for treatment. So I wouldn't do continuous. I would only do it after sex, so that you hopefully get less doxy courses in a month than you would need if you actually contracted chlamydia and needed doxy, or syphilis in this case with penicillin shortages.
Any suggestions how to decrease the pain of injection from lenacapavir?
Oh, I agree that there's pain with that drug, and we do lidocaine patches before, because we can't not admit that there's pain and there's nodules, persistent nodules. That was shown in Capella and Calibrate studies together in our last CCO meeting after IAS. So definitely that's the one where we use lidocaine, and we've talked to the drug company and they said that they use lidocaine too. So we don't even go for numbing it with cold or rubbing it or anything. We go straight to lidocaine.
Yeah, the other thing we've done here is we'll have patients, in this case, pre-medicate with ibuprofen a few hours before they come in. Anecdotally, that seems to help. Whether it does or doesn't, I don't know. It's not a randomized study, but we've done that. So that may be another. Our experience is that the more kind of subcutaneous tissue you have, the somewhat less painful it is. And so someone who's really thin and limited subcutaneous tissue, they tend to have the hardest time. Monica, do you inject lidocaine or just use a lidocaine patch?
We do the patch, yeah.
Yeah.
Or cream.
I agree. That's what we do.
Yeah.
All right. I think we're pretty much done. Monica, any last words, or are we good?
I think we're good. And thank you so much, everyone, for joining us.
Yeah, this was really terrific. Thank you all.
Thank you to Dr. Eron and Dr. Gandhi for that excellent discussion. For more information on the full program, CCO independent conference coverage, clinical impact of new HIV data from CROI 2024, you will find the direct link to the CCO website in the show notes for this episode. And finally, thank you, our listeners, for joining in for today's episode.